Hello everyone, good morning. So today we are going to talk about a very important topic, flap surgery. Okay, this is one of the very important aspects of periodontology. So once you get to know about the basics, the flap surgery or any surgical aspect is going to be a cakewalk. Okay, I will be using a lot of terminologies like gingiva, keratinized gingiva, width of attached gingiva. So once you know the basics, you know the terminologies, it will be a cakewalk. Okay, so if you have not watched the previous videos, you just go back, watch the basic tissues, then you can watch this video, so it will be very easy for you to understand. Okay, fine. So periodontal flap surgery. Okay, one of the key aspects in perio. So what is a flap? A flap in any part is a section of a tissue. Okay, in this case, it's going to be a section of a gingiva. You see here, this portion of gingiva, okay, where I'm going to give incision, I'm going to elevate with the periosteal elevator and I'm going to reflect it away from the bone, right? This portion of gingiva is called as the flap. Okay, so now I'm going to give a definition for it. Periodontal flap surgery is defined as the section of gingiva that is surgically separated from the underlying bone. Okay, that is surgically separated from the underlying bone. Why we need to do or why we need to reflect a flap? Exactly, to visualize, to get access to the root surface and the bone, right? Separated from the bone to visualize and to gain access, to visualize and to gain access to the roots and bone. Fine. So as I told earlier, flap is a section of gingiva which is surgically separated from the underlying tissues so that I can visualize and I can bring my instrument inside the bone and the root to remove any kind of subgingival calculus or granulation tissue. Okay. Now I'll next moving on to the classification. Okay, so classification of flap will be very simple. Okay, see, this first one will be based on reflection. Okay, so after giving incision, I'm going to reflect the flap, then I'm going to elevate the flap. Okay, it depends upon the type and the need and the requirement of the particular site. I'm going to raise whether a full thickness flap or a partial thickness flap. What do you mean by a full thickness flap? Full thickness flap is if I elevate the epithelium, the connective tissue and the portion of periosteum. Okay, if I reflect the epithelium plus connective tissue plus periosteum. Okay, so all these three, if I give an incision, reflect and elevate, then that becomes a full thickness flap. Okay, next one is partial thickness flap. Partial thickness flap is if I elevate epithelium plus some portion of connective tissue. Okay, so if I reflect the epithelium and some portion of connective tissue and I leave the remaining portion of the connective tissue and the periosteum attached to the bone itself, then that becomes partial thickness flap. So partial thickness flap or split thickness flap we predominantly use in mucogingival surgeries or perioplastic surgeries. Okay, full thickness flap mostly recommended in case of any bony deformities or I want to correct any abnormalities in the bone, bony recontouring needs to be done, then I will reflect a full thickness flap. Okay, so the first classification is going to be based on reflection. So if I elevate the entire epithelium, connective tissue and the periosteum, it becomes a full thickness flap. Or if I elevate only the epithelium, some portion of the connective tissue, whereas I leave the remaining portion of the connective tissue and the periosteum, then that becomes split thickness or partial thickness flap. Okay, sorry. So the next is going to be based on management of papilla. Okay, what do you mean by papilla? Basics. Interdental papilla fills the embrasure spaces. Okay, so why it is needed? To maintain the aesthetics. If there is no internal papilla, black triangle, an aesthetic. So most of the times, or especially in the anterior region, we should always try to preserve the papilla. And also, if I don't preserve the papilla, or if I cut the papilla in the anterior region, and if I do, give incisions at the wrong place, then that might lead to black triangle formation and recession. So most of the times, if there is spacing in the upper anteriors, especially when there is more amount of diastema or frenal attachment, eye frenal attachment, the patient is having spacing, you have to do a procedure called as papilla preservation technique. Okay, wherein I'm going to preserve the internal papilla, and I'm going to reflect it either buccally or lingually. I'll tell you how, and when we look at the procedures, I'll tell you what is papilla preservation and how it is done. So as of now, based on the management of papilla, flaps can be classified as papilla preservation flap, where I'm going to preserve the internal papilla as in cases of midline diastema or spacing. So the next one will be the conventional flap. Next one will be the conventional flap surgery, where I'm going to give incision. Okay, and I'm going to elevate the flap in a very normal way. I'm not going to preserve the papilla. I'll give circular incision, I'll give interdental incision, and I'll reflect the flap. We'll see all the incisions in the upcoming slides. Okay, so conventional flap and papilla preservation flap, these two vary. If I preserve the papilla, as in case of diastema, that becomes papilla preservation. If I don't preserve the papilla, which means I'm just doing a normal conventional flap technique, that becomes conventional flap procedures. Okay, based on the placement of flap. Okay, so based on the placement of the flap after reflection, it can be classified as displaced and undisplaced flap. Self-understanding, right? So if I give incision, raise a flap, whatever flap it might be, full thickness or split thickness, if I'm going to suture it to the original place, then that becomes undisplaced flap. I'm giving incision, reflecting the flap, I'm going to keep it just apically to the original position or coronally to the original position, that becomes displaced flap. Okay, so we are going to classify flaps based on three conditions. One is based on reflection. I'm going to classify that as full thickness or partial thickness. So full thickness means epithelium plus connective tissue plus periosteum. Partial thickness means epithelium plus some portion of connective tissue. Next is going to be the management of papilla. So I am going to either preserve the papilla in case of diastema, cases of spacings, or I'm going to do a conventional flap procedures. Next one is based on the placement of the flap. I'm going to place the flap in the original place, then that becomes undisplaced. Or if I'm going to pull the flap apically or coronally, that becomes displaced flap. Fine, very good. So now moving on to the goals of flap surgery. Why do we need to do a flap surgery? I'll tell you a very easy and a very self-explanatory goals of flap surgery, which you no need to memorize at all. Okay, so the first one is, see, I'm going to visualize the bone. That is the definition of flap, right? A flap is a section of gingiva which is surgically separated from the underlying bone so that I can see and I can insert my instrument and do debridement, right? So first goal will be to visualize the bone. First one is to visualize the bone and the root surface, which is followed by debridement. Debridement is nothing but scaling and root planing. What I am going to do in scaling and root planing, I am going to remove the subgingival calculus, any contaminated cementum, any kind of block attached to the root surfaces, and I am going to make the root clean, smooth surface. Okay, so the end point of debridement or scaling and root planing will be clean smooth surface. So I'm reflecting the flap, visualizing, put in the instrument, make sure it is clean and smooth. A third one will be if at all, there is any kind of a bone defect, so okay, I'll try to regenerate it, right? So regeneration of the lost structures, whatever it may be. It can be the PDL, it can be PDL, it can be cementum, it can be alveolar bone, whatever it may be. Okay, I'm trying to regenerate the lost structures like PDL, cementum, bone. Okay, so the next one will be, okay, I'm giving incision, I'm raising the flap. Okay, just that I know to reflect the flap or I know to elevate the flap surgery is not going to end. It is going to end by proper suturing again, either displaced or undisplaced, whatever it may be, by proper suturing. So, what I will do is I will try to maintain the physiological architecture. Okay, so I will try to maintain the physiological architecture or the physiological contour of the gingiva, and I will try to restore it the same way as possible. Okay, so these are all the four goals of flap surgery: to visualize the bone root, to put the instrument, to gain access to the instruments for debridement, scaling and root planing, clean smooth surface. If at all any defects, I'll go for regeneration of PDL, cementum and bone, and also to restore the physiological architecture, right? Fine. Now coming to the indications of flap surgery. Okay, so flap surgery, lots of you would have been having doubt that when I will decide that this case will go for flap surgery and this case will not go for flap surgery, and scaling and root planing is sufficient to manage this case. Okay, so previously scaling and root planing was called as curettage. Okay, now the term curettage has been removed because curettage means I'm removing only the soft tissue wall of the pocket. Okay, I'm not going to remove the local factors. The local factors are nothing but block and calculus. So when block and calculus are not removed, even though I remove the pocket lining completely, I'm not eliminating the bacteria. I'm not going to remove the bacteria. So when I don't remove the bacteria, obviously the infection is going to recur again. So what they did was the term curettage was removed and they replaced it with the term called scaling and root planing. Scaling and root planing. What is scaling and root planing is very simple. I'm going to remove the subgingival calculus, subgingival block, contaminated cementum. Okay. Then you can ask me, so what will happen to the soft tissue lining? Okay. You're just removing the block and calculus which is attached to the cementum, and also you're removing some kind of a contaminated cementum. But what will happen to the soft tissue lining of the pocket, which we are not going to remove in scaling and root planing, right? So then what happened was they found out that while doing and scaling and root planing, there was an accidental removal of the soft tissue lining of the pocket. Okay, while doing scaling and root planing, while giving short powerful pull strokes, I can able to see that some amount of granulation tissue also come out accidentally, and they call that as inadvertent curettage. Okay, inadvertent curettage. Okay, so inadvertent curettage is nothing but accidental removal of the soft tissue lining of the pocket while doing scaling and root planing. So what they found out, the scaling and root planing, it fulfills the entire criteria of removing the local factors, removing the endotoxins and the contaminated cementum, as well as it eliminates the pocket lining, or it removes the pocket lining and the granulation tissue. Okay, so the curettage term was removed and scaling and root planing term was introduced. Fine. Now, which cases ideally goes for flap surgery and which cases scaling and root planing is enough, and in which cases even scaling and root planing is not needed. Okay, so this graph, or this whatever you call it, this is called as critical probing depth. Okay, so critical probing depth was given by Linde 1982. Okay, what they proposed was they set up certain probing depth values. Okay, that it should be above this value to do a particular treatment, and if it is below, you can do this treatment or no treatment. Fine. So say for example, if the probing depth is more than 2.9 mm, then we can do scaling and root planing. Okay, if the patient is having probing depth of more than 3 mm, say for example 3 mm, then I can do scaling and root planing. What will happen if I do scaling and root planing for a patient who is having less than 3 mm of probing depth? Is, according to this concept, they say that if you are doing any procedure that does not match the critical probing depth value, that will result in clinical attachment loss. And if I do any procedures which are indicated according to this critical probing depth, say for example in this case probing depth of more than 3 mm, if I do SRP, then there will be clinical attachment gain. So if I do any procedure which meets the critical probing depth value, then there will be gain. If I am doing SRP for a patient less than 3 mm, then there will be clinical attachment loss, never gain. Okay, now coming to flap surgery. So flap surgery would be 5.4 mm. If the patient is having probing depth of more than 5.4 mm, after scaling and root planing review, say for example in phase 1 I'll be doing scaling and root planing, I'll send the patient and I'll ask them to come after 2 to 3 weeks for the evaluation of the soft tissue, because the complete epithelialization takes place around 2 to 3 weeks and the connective tissue formation takes place around 2 months. So I'll be calling around 3 to 4 weeks, and then I'll probe the area. Okay, so during that time, if the probing depth is more than 5.4, only those patients should be taken up for flap surgery. What will happen if I do flap surgery for a patient who are having less than 5.4 mm after scaling and root planing? There is going to be clinical attachment loss. What happens if I do flap surgery for a patient more than 5.4 mm? Obviously, there will be clinical attachment gain. Okay, this is how they scrutinize on how or what patients are ideal candidates for flap surgery. Okay, and this is for modified Widman flap 4.2 mm, for modified Widman flap. So patients having 4.2 mm can be taken up for modified Widman flap procedure. But again, the modified Widman flap has a lot of specific characteristics which we'll be discussing further. So generally speaking, patients more than 3 mm can be taken up for scaling and root planing. Patients more than 5.4 mm after 3 to 4 weeks of recall after SRP can be taken up for flap surgery. So I hope this is clear, right? Okay, now moving on to the contraindications. Okay, now indications. Speaking about the indications, overall needs flap surgery. Patients who are having, this is secondary. So broadly speaking, patients with infrabony defects, patients with osseous craters, patterns of bone destruction, osseous craters, one third of total defects, two-thirds of the mandibular defects, right? So the buccal and lingual all be same. There will be depression in the center. Next, grade 2, grade 3 furcation, hemiseptum, hemisection or root resection, periodontal abscess. Okay, patients who need crown lengthening. Okay, patients who need crown lengthening. So these are all patients or patients with pockets of 5 to 6 mm according to the critical property type. So these are all the patients, ideal candidates who might require flap surgery in the future. Okay, now coming to the contraindications. So the contraindications are very simple. If the patient is having any uncontrolled systemic conditions, okay, any uncontrolled systemic conditions, uncontrolled diabetes, uncontrolled hypertension, or patient who is having stroke or ischemic heart disease less than 6 months, MI less than 6 months should never be taken up. Okay, patients who are having poor maintenance, unrealistic expectations, patients who do not maintain properly, patients, despite of giving oral hygiene instructions, despite of teaching them the methods to how to brush or how to use a mouthwash, they don't properly follow. Obviously the treatment is going to become a failure because the constant presence of local factors is going to cause damage to the periodontium, and again it's going to be a failure. Unrealistic expectations, like, doctor, if you do this procedure, my tooth should be absolutely fine. I should eat like when I was 20 years. No, those are all unrealistic expectations. So patient who's having unrealistic expectations, either explain what is happening in their mouth or oral cavity, or you just neglect them, don't do the treatment. Okay, so either the patient is having uncontrolled systemic conditions, or patient who had undergone MI, stroke, ischemic heart diseases in less than 6 months of time, poor maintenance, unrealistic expectations, don't do flap surgery, just leave them. Okay, now coming to the very important aspect called incisions. Okay, so incisions we are going to give with help of BP handle, Bart Parker handle, and a BP blade. Okay, so there are n number of blades. Okay, say for example 11, 10, 15, 12. Okay, these are all the various sizes of the blades, and each blade size will we will select for each kind of procedure. Say for example, for any stab incision for draining a periodontal abscess, we can use 10 blade. And for, as we are going to discuss, I'll tell you what are the remaining blades they are used for. Okay, most commonly we use 15 size blade. Okay, now coming to incisions. Okay, so incisions, if you see, why is incision very important? Can anyone tell me why incision is very important, especially when you are doing flap surgery, or especially you are doing any kind of periodontal procedures? Okay, the thing is, if I don't give an incision properly, or if I give an incision which is not adequate for the reflection and the elevation of the flap, I'm going to encounter enormous bleeding. That bleeding will be predominantly from the periosteum of the bone and the granulation tissue. Okay, if it is from the granulation tissue, I remove the granulation tissue with the curette, the bleeding is going to stop. If it is from the periosteum, unless and otherwise I remove the periosteum, or I am going to elevate it again with the periosteum, there's going to be continuous bleeding. So incision should always be precise, whatever incision it may be. We'll be discussing about lot of incisions. So incision should be at the desired height. Say for example, if I want to reflect a full thickness mucoperiosteal flap, one of my incisions should completely hit the bone. So if I don't hit the bone and I try to reflect the flap, it is not going to reflect fully. Obviously the periosteum is going to get attached, so there will be definitely encountering of enormous bleeding. Okay, so the incision should be very properly given. Okay, and also, if you follow certain principles how to use a blade, Okay, see, this is a blade, right? So this is the bevel of a blade. Okay, this aspect of a blade is the bevel of the blade. This one is the bevel of the blade. It should always face the cutting side. If I keep the bevel like this and if I do the cutting in this direction, then there's going to be blunt dissection. Okay, so the bevel of the blade should be towards the side where I'm going to cut or place an incision. Okay, fine. Now the first incision what we are going to look is the external bevel incision. Okay, so predominantly given with 11D or 15 size blades. Okay, 11D or 15 size blades. So what is external bevel incision is very simple. I'm going to place the bevel of the blade towards the tooth. Okay, now use your common sense and tell me, am I going to hit the bone? No. Why? Because I'm going to face the bevel towards the crown. I'm not going to face it towards the crest. So only if I place the bevel towards the crest, I'm going to hit the bone. Now I'm going to hit the tooth, external bevel. So I'm going to place it towards the crown, towards the coronal aspect, right? So see, as you can see in the image, I'm placing the bevel of the blade towards the crown. Okay, so I'm just running it through the gingiva and I'm going to remove the piece of tissue. Can anyone tell me what is this procedure? Exactly, this is called as gingivectomy. So what incision I'm going to give for gingivectomy? External bevel incision. Am I going to touch the bone? No. Where should my bevel point? Towards the tooth. So as you can see in this image, the incision faces the tooth. I'm going away from the bone. I'm going away from the bone. So this kind of incision is called as external bevel incision directed towards the tooth. It is used to remove the excess amount of gingival tissue, or in cases of crown lengthening where I don't need any kind of osseous reduction. Okay, so the first incision what we are talking is the external bevel incision, 11D or 15 size blade. In the bevel points towards the tooth. Fine. The second incision what we are going to see is a very important incision called as internal bevel incision. The second incision, according to the incision lining I mean the order I'm saying, this incision is called as internal bevel incision or primary incision or first incision or reverse bevel incision or inverse bevel incision. Too many names, right? So the internal bevel incision is otherwise called as primary incision, first incision, reverse bevel incision or inverse bevel incision. Okay, whatever incision they can ask you in any of these names. So in internal bevel incision is the first incision in most of the flap surgeries. Okay, so it is done using 15 size blade. Okay, very important thing about internal bevel incision is, as you can see here, as you can see in this image, okay, it is given slightly away from the gingival margin. Am I right? This incision starts slightly away from the gingival margin. What is that slightly? 0.5 to 2 mm away from the gingival margin. Okay, so the internal bevel incision starts 0.5 to 2 mm from the gingival margin. What is the bevel facing towards? The bone. In external bevel, it was something like this, right? In internal bevel, I'm going to place the incision facing the bone. Okay, so 0.5 to 2 mm from the gingival margin. This is the bevel, right? This is the bevel. The bevel hits the bone, and the blade should run towards the direction of bevel, which means it should run in this direction. So I should cut it somewhere here, and I should go here. Okay, if what happens if I do a back dissection, then that is going to result in blunt dissection. Okay, so internal bevel incision is a first incision or a reverse bevel incision. It is given 0.5 to 2 mm from the gingival margin, and it is going to hit the bone. Okay, now am I right in saying that this tag of tissue this tag of tissue contains pocket lining? Obviously this tag of tissue is going to contain pocket lining. Okay, so in the future incisions, I'll tell you what will happen to this tag of incision or piece of tissue, this tag of tissue, this 2 mm of the marginal gingiva which is left over by the internal bevel. Okay, so okay, now internal bevel incision, first incision, inverse bevel, reverse bevel, incision directed towards the bone, 15 size blade. Okay, and it is going to be 0.5 to 2 mm from the away from the gingival margin. Okay, very good. So next incision will be sulcular or crevicular incision. Sulcular or crevicular incision. So what do you mean by a sulcular or a crevicular incision? Is very simple. It is a second incision. What I'm going to do is I'm going to just insert the blade into the sulcus. I'm going to just run the blade inside the sulcus. I'm not touching the internal papilla, just the sulcus, running the sulcus. Take it, sulcus, just release the fibers alone in the sulcus. Take it, sulcus, release the fibers. That is called as crevicular incision. So now by this time, we'd have put internal bevel incision. Okay, so you take a look at this case. First incision is internal bevel incision. Okay, so after putting the internal bevel incision, I am going to insert the blade into the sulcus. One thing you have to remember is the incision aspect, this area. Some will think that I should insert the blade in this area where my incision is placed when I'm placing the internal bevel. No, the incision should be placed in the normal sulcus. Okay, so I'm going to insert the blade into the sulcus and I'm going to run it like this. Okay, till I hit the bone. Okay, so I'm inserting the blade into the sulcus, I'm going to hit the bone, I'm going to run. So I'm not coming into the internal papilla region, I'm just running it in the sulcus region, right? Fine. Now this is a second incision. This is called as sulcular incision given with 12 size blade. Now coming to the third incision. Okay, third incision is nothing but it is the interdental incision. Okay, so interdental incision. Interdental incision is, I have given internal bevel incision, I have given sulcular incision. Now if I break the internal papilla, then that piece of tag of tissue is going to come out, right? It remains attached only to the internal papilla. So if I give a third incision, that is interdental incision using Orban's or Kirkland knife, if I give interdental incision, this piece or this tag of tissue is going to come out, isn't it? So I have given internal bevel incision which is 0.5 to 2 mm from the gingival margin. I have given sulcular incision entering into the sulcus, and then I am extend interdentally and I am breaking the papilla. So once I break this papilla, this tag of tissue, okay, this tag of tissue is going to be removed, isn't it? That is going to get removed. So by this way I'm going to remove the pocket lining. Am I right? Remove the pocket lining. So you just use your common sense and tell me, am I right in saying that wherever I'm giving internal bevel incisions, that becomes a pocket elimination procedure? That becomes a pocket elimination procedure. What does that mean? I am completely removing the pocket lining. Okay, I'm giving incision, I'm completely removing the pocket lining, isn't it? So patient in flap surgeries where I'm giving internal bevel incision to the patient, that becomes pocket elimination procedure, because I'm going to remove the small piece of tag of tissue which contains the pocket, right? Very good. So we have seen about 4 incisions: external bevel, incision directed coronally, gingivectomy procedures, and internal bevel incision. First incision, primary incision, it is directed towards the bone. Sulcular incision, it is directed into the sulcus. Interdental incision, it is given to break the interdental papilla or the contact point. In this way I'm going to remove the piece or tag of tissue. Okay, fine, very good. So moving on to the next incisions. So till now what we saw was horizontal incisions. Okay, the external bevel incision or the internal bevel incision and the sulcular interdental incisions, all these are horizontal incisions. Fine. Now coming to vertical incisions. So if you take a look at the vertical incision, there will be set of rules. There are set of rules for placing a vertical incision. You cannot place a vertical incision just like that. Take a plate, just place vertical incision. No. What happens if you place like that? There are chances of recession. There are chances of compromised blood supply, post-operative discomfort, shrinking of gingiva, sensitivity, pain. Okay. Now, what are the set of rules? So, the first set of rules for the vertical incision is the first and foremost rule is you should never ever break the papilla. Okay, never break or split the interdental papilla. Okay, you should never break or split the interdental papilla. Okay, then where should I put the incisions, sir? Very simple. You have to put the incisions along the line angles of the tooth. Okay, either you have to involve this papilla or you have to exclude this papilla. In this case I am excluding the papilla of canine. The mesial papilla of canine has been excluded. I am not involving the papilla. And your incisions should never be like this. Sorry, your incisions should never be like this, splitting the papilla. Either you should involve the papilla or exclude the papilla, and the incision should be along the line angles of the tooth. Okay, so the vertical incision what I'm placing, it should be along the line angle of the tooth. And then the base to the apex ratio, the base should always be broader than the apex. So this is called as the base. This is the base. This is the apex. So the base should always be broader. So I can give an incision like this, or as you see in the image. Okay, but never like this. If I put an incision like this, then base becomes less than the apex, then that is going to result in compromised blood supply, and more importantly, if I don't follow this rule, there is going to be tearing of the flap. Again, if I tear a flap, I have to manage it in a different way, which is a bit difficult. Otherwise, that might lead to recession and sensitivity. Okay, so one of the most important thing which you should take care, or which you should keep in your mind while doing a flap surgery is, if you are not doing the procedure properly, take it from me, you are exaggerating or aggravating the existing problem. Okay, if you're not doing it properly, you are going to aggravate the existing problem. What does that mean, sir? Normally the patient would have a grade 1 mobility, you're not doing it properly, grade 2, grade 3 tooth fall off. Patient normally would have not had sensitivity, but if you showed them the x-ray, wrong technique, skill, sensitivity lifelong. So you should be very careful in choosing the patient and to give what incision, to give a correct incision. Okay, so these are all the few set of rules for vertical releasing incisions, right? So we'll talk about another few incisions. So this is called as thinning incision. What do you mean by thinning incision is very simple. See, let me show you an image. Okay, so you take a look at this patient. So this is a flap, right? Section of gingiva which is surgically separated from the underlying bone. So once I reflect a flap, this portion of the flap, will be thick. Okay, it will be thick. It will be having lots of granulation tissue and some kind of connective tissues, infections, bacteria, whatever it may be. So what I will do is, I'll just trim the portion. I'll just trim this portion so that the flap becomes thin. What does it need to do that? If I make the flap thin by cutting out the excess tissues, I'm going to properly adapt the tissues to the bone. Okay, I'm going to properly adapt the tissues to bone. So the first and foremost thing why we need to do a thinning incision is to properly adapt the tissues to the bone. Okay, so reflect the flap will be thick. With the help of scissors or with the help of BP blade, just trim the flap. So by trimming the flap, I'm removing the excess tissues, I'm making the flap thin for proper adaptation onto the bone. Fine, this is called as thinning incision. Next one is the cutback incision, as you can see here. So cutback incision, as you can see here, very simple. I'm just giving a small cut back. Why? For the proper stretchability, extensibility of the flap, so that I can pull it laterally or coronally if at all I need. For proper stretchability of the flap, and also to put a tension free flap. Okay, so if I want to put a flap, if I want to suture the flap without any tension, but that area has a muscle pull, or that region has a insufficient vestibular depth, then I might need a small cutback incision so that I can pull and suture the flap without any kind of tension. Okay, this cutback incision is most commonly used for laterally positioned flap, which we will be studying when we read about mucogingival surgeries or perioplastic surgeries. Okay, so the cutback incision is given predominantly for the stretchability and extensibility of the flap. Okay, so it is predominantly used in laterally positioned flap. So the next incision what you are going to see is the periosteal releasing incision. Okay, next incision what you are going to see is the periosteal releasing incision. What do you mean by periosteal releasing incision? Is very simple. In periosteal releasing incision, as you can see in this picture, the flap is reflected and I'm giving incisions on the bottom of aspect of the flap, somewhere here. Why we need to give incision somewhere in the bottom of the flap? To reflect it further, to stretch it coronally, so that I get enough closure without tension. Very similar to cutback incision. Cutback incision I am giving just for proper pull, extension, flexibility. And again, periosteal releasing incision, say for example, I'm extracting a tooth, I'm doing a socket preservation. So when I extract the tooth and suture, there will not be proper closure. Obviously, there will not be closure because there was tooth, and if I remove the tooth and I just suture, it not going to close properly. In those cases, what I'll do is I'll just raise the flap, give periosteal releasing incision, I'll go as deep as I can, and then I'll try to pull it and suture it. That is called as periosteal releasing incision, done to attain or to get a proper closure of the flap. Okay, very good. So these are all the few incisions which we have learned now. External bevel incision. So incisions are broadly classified as horizontal and vertical. So we have seen about the horizontal incision, external bevel, internal bevel incision, circular incisions, interdental incisions, and also vertical incisions. There are a few set of rules for vertical releasing incisions, when and where to put a vertical releasing incision. Fine. And also we have talked about thinning incisions, periosteal releasing incisions, cutback incisions, where you cannot see this anywhere in your textbooks. Okay, fine. Now moving on to the design of a flap. Okay, so flap design, if you see, it can be with vertical releasing incisions or without vertical releasing incisions. So with vertical releasing incisions or without vertical releasing incisions. So with or without vertical releasing incisions, what does that mean? Is very simple. So you take a look at the first picture, this picture. I'm going to give circular incisions. I'm not going to give any kind of vertical releasing incisions. I'm going to give internal bevel, circular, interdental, or just circular and interdental, and no vertical releasing incisions. This kind of flap technique is called as envelope flap technique. This design of flap is called as envelope. There are I can give two vertical releasing incisions for a flap. This is called as pedicle flap design, or one vertical releasing incision. This is called as triangular flap technique. So the three flap design which we have learned now is envelope, pedicle, or triangular flap design. Okay. Next one, what you are going to see is the flap reflection and flap elevation. Okay, flap reflection and elevation. What do you mean by flap reflection and flap elevation? Very simple. So we are going to use what instrument to reflect and elevate the flap? Exactly, we are going to use periosteal elevator. Number 9 periosteal elevator, Moll's periosteal elevator, whatever it may be. So I am going to use a periosteal elevator. I will be having a sharp end, and also I will be having a broader end, isn't it? So ignore the image. Okay, so imagine you're having a periosteal elevator which is having a bit sharper head or edge on one side, and you'll be having a spoon shaped broader end on the other side, isn't it? So after giving incision, I should use this sharp end of the periosteal elevator to make sure that the interdental papilla and the marginal gingiva are detached from the bone, okay, or detached from the bone. So I should use this sharp end of the periosteal elevator so that the interdendal papilla and the marginal gingiva gets detached from the bone. Okay, now after the marginal gingiva and the interdendal papilla are detached from the bone, I should use this broader end to elevate the flap. Okay, to elevate the flap. So flap reflection is done by the sharp end, the smaller sharp end. Flap elevation is done by the broader end. For example, a full thickness mucoperiosteal flap. Right? So once I give incision, I'll use the sharp small ends to give or to reflect the margin gingiva and internal papilla from the bone. Once I reflect it, I'm going to elevate it with the broader end. So this is what flap reflection and elevation is about, right? Fine, clear, very good. Now I'm going to talk about a very few flap techniques which we are using, or some procedures which you are not using currently. Okay, it will be very simple, very easy, just listen carefully. Original Widman flap, the first one, it is given by Widman, obviously, in 1918. Okay, so the original Widman flap was given by Widman in 1918. What is this technique is? This technique implies it is a pocket elimination procedure. So am I going to use internal bevel incision here? Yes. So obviously I'm going to use internal bevel incision. So original Widman flap is a pocket elimination procedure. It came by Widman in 1918. Okay. So how to do a original Widman flap is very simple. First, I'm going to give vertical releasing incisions. Okay, the first step is vertical releasing incisions, which is followed by as you can see, vertical releasing incisions, which is followed by internal bevel incision plus sulcular or crevicular plus interdental papilla. So once I give all this, the tag of tissue is removed. Excellent, the tag of tissue is removed. Okay, see, I'm giving vertical releasing incisions. Okay, and then I'm giving internal bevel incisions. See, as you can see, a small tag of tissue which is left. Isn't it beautiful? Isn't it? So I'll be giving sulcular, interdental, and I'll just take away this tag of tissue. Okay, and then I'm going to recontour the bone. As you can see here, I'm going to recontour, or I'm going to remove the crestal bone. Very important thing, I'm removing the crestal bone. And then what I'm going to do is I'm going to place sutures. Okay, vertical releasing incisions, internal bevel, sulcular, interdental, raising the full thickness mucoperiosteal flap, doing bony recontouring, reducing the alveolar crest, suturing. Okay, very good. Next technique what we are going to see is the Newman flap. So Newman flap is given in 1920 by Newman. It is very similar to original Widman flap, except the part of sectional vertical releasing incisions are given here. Like say for example, if I see pocket in only 2 teeth, I'll give only vertical releasing incisions in that region alone. I will not be giving the entire quadrant. Okay, so vertical releasing incisions are limited to sections. So in that way, it varies from original Widman flap. Minor variations. Other than that, it is very similar. Vertical releasing incisions, internal bevel, clavicular circular, internal reflect the full thickness flap, recontouring and placing at the, one thing you have to remember here, I am placing the flap at the crest of the bone. I am placing the flap at the crest of the bone. Now use your common sense and tell me, is it a displaced or undisplaced flap? Is original Whitman flap a displaced or undisplaced? Excellent. It is a displaced flap. Why? Because I'm not placing the flap at the original position. Original position, it was like this. But at the end, I'm going to suture it at the level of the alveolar bone or crest. So I'm displacing the flap apically. It is a pocket elimination procedure, and I'm displacing the flap apically. Newman flap, again, it's very similar to original Whitman. It is also a displaced flap where it varies in section, giving sectional vertical releasing incisions. Fine. Now the third one, what we are going to, third flap technique, what we are going to do is, or what we are going to see is the modified Whitman flap. Okay, yeah. So the third technique what we are going to see is the modified Whitman flap. It was given by Ramford and Nissel in the year 1974. Okay, what do you mean by modified Whitman flap? Okay, I'll tell you what is the modifications apart from the original Whitman. So original Whitman, again, vertical releasing incision, internal bevel, circular or clavicular, internal incision, raising a full thickness mucoperiosteal flap, removing the granulation tissue. I'm reducing the crestal bone, suturing it apically at the level of crest of the alveolar bone. So that it becomes a displaced flap. Now modified Whitman flap was given by Ramford 1974 and Nissel. What they told was very simple. Here there is no vertical releasing incisions. Can anyone tell me what is the drawback of vertical releasing incisions? As I told, yes, aesthetically compromised. So when I give an vertical releasing incisions in my anterior region, what is going to happen? Definitely it is not going to look aesthetically good. Definitely it's not going to look aesthetically good, right? So I should think twice or thrice before doing an original Whitman flap or a Newman flap in the anterior region. Whereas the modified Whitman flap, there is no vertical releasing incisions, right? So I can easily use it in aesthetic areas. I'm going to use that easily in aesthetic areas, right? And also I am going to suture it to its original position. These are all the two modifications of a modified Whitman flap apart from the Whitman. So there is not going to be any vertical releasing incision, and also I'm going to suture it back to the original position. Now tell me whether it is a displaced or undisplaced flap. It is going to be a undisplaced flap. Okay, so the modified Whitman flap becomes a undisplaced flap. Why? Because I'm going to place, or I'm going to bring the flap back to its original position. Okay, so now what is the technique? Very simple. Pocket is being measured in the first image. Okay, pocket is being measured, and then what I'm going to do, as you can see beautifully here, see this tag of tissue, isn't it? What is this incision? Excellent, this is an internal bevel incision. Okay, how much distance? What is the distance from gingival margin? What is the distance from gingival margin? 0.5 to 2 mm away from the gingival margin. I am going to give internal bevel incision, which is otherwise called as the reverse bevel incision or the first incision or inverse bevel incision or a primary incision, 0.5 to 2 mm away from the gingival margin, directed towards the bone. If it is direct towards the teeth, that becomes external bevel incision gingivectomy procedures. Okay, so internal bevel gingivectomy, it removes the pocket lining. So the first one is internal bevel incision. After the internal bevel incision, what I'm going to do, ignore this picture, I'll tell you what is papilla preservation later. And I'm going to raise a full thickness mucoperiosteal flap here. Okay, so can you see the what is this? What is this? These are called as ledges, patterns of bone destruction. Previous chapter, previous videos. Patterns of bone destruction, ledges, plateau-like margins. It is because of the resorption of the thickened bony plates, bony buccal plates. Okay, so this is called as ledges. Okay, now I'm going to give internal bevel incision, which is followed by second incision, sulcular, which is followed by interindial incision. I'm going to remove the tag of tissue, which is nothing but pocket lining, and then I'm going to raise a full thickness mucoperiosteal flap. Full thickness. It should involve epithelium, connective tissue, plus the periosteum of the alveolar bone. Okay, so I'm raising a full thickness mucoperiosteal flap, and then I'm going to debride the area and I'm going to suture the area. Okay, so as you can see, I'm raising a full thickness flap palatally as well, and I'm going to nice debridement done here. As you can see, there's nice debridement done here. Okay, I can able to visualize the bone correctly, and I'm going to suture it back to the original position. Okay, the original position where I saw here. That is the reason why modified Widman flap is a undisplaced flap. Where it is indicated for marginal Widman flap, one of the main indication is there should be adequate width of attached gingiva. So imagine if the patient is not having adequate width of attached gingiva, you are doing modified Widman flap, that might result in recession. Okay, because I'm removing a piece of tissue and I'm suturing it back to the original position, so I'm giving it intention, right? So if the patient is not having adequate width of attached gingiva, or if the patient is having recession, already the patient is having recession, I should never do a modified Widman flap. There should be adequate width of attached gingiva or width of keratinized gingiva, and also the patient should not have recession. Okay, because a general side effect, you can say, or a complication, you can say, of flap surgery is recession. There will be mild recession. What happens if I do a modified Widman flap in a patient who is already having recession? I'm going to aggravate the situation. It's going to become worse. Okay, so there should be adequate width of attached gingiva or adequate width of keratinized gingiva. Fine, very good. So the next one what we are going to see is the conventional flap technique, which is nothing but Kirkland flap or modified flap operation. Okay, so it's Kirkland flap or modified flap operation. So this technique was given by Kirkland in the year 1931. Okay, Kirkland flap or modified flap technique was given by Kirkland in 1931. This technique, what I'm doing is, I'm not giving internal bevel incision. This is a normal routine flap technique which most of the times we use. Okay, there is going to be no internal bevel incision. There's going to be only two incisions. I'm going to give only sulcular and interdentine incisions. Okay, so I'm going to insert the blade, as you can see here. Okay, as you can see here, I'm inserting the blade into the sulcus, and I'm going to enter the interdentine papilla, break the connection between the papilla, and then I'm going to raise a full thickness mucoperiosteal flap, do a nice debridement, suture it back to the original position. In this way, it again becomes a undisplaced flap. Okay, it becomes a undisplaced flap. Okay, so if I'm going to raise a flap, if I'm going to raise a flap without giving an internal bevel incision or a reverse bevel incision, I'm just giving circular incision and the interdental incision. I'm raising the flap, doing a nice curettage, suturing it back to the original position. Right? This is called as Kirkland flap or modified flap operation, 1931, most commonly used flap technique. Okay. Next one is the palatal flap. See, whenever you raise a flap buccally, you should also raise the flap palatally. There are a few concepts now arising like single flap approach. Okay, single flap approach is nothing but they say that only buccal reflection of the flap is enough. Do a nice curettage, suture it off, or nice scaling and root planing, suture it off. Or sometimes a few authors say that no, double flap double flap elevation is needed. Single flap approach and double flap approach is definitely needed because in double flap we are going to reflect the buccal as well as the palatal or the lingual papilla or the lingual gingiva. Okay, so in that way palatal mucosa, palatal gingiva, it blends the palatal attached gingiva, it blends with the palatal mucosa, so it has increased amount of keratinized tissue, which means it has less elastic fibers. Okay, so I cannot, or I should most of the times avoid vertical releasing incisions palatally. I should avoid vertical releasing incisions palatally, or I should be using it with caution to avoid any vital structures. Okay, but I can give internal bevel incision palatally also. Okay, so internal bevel incisions can be given, but you make sure you are not giving vertical releasing incisions because once you know some important landmarks, you try to avoid that. Other than that, you can give vertical releasing incisions. You cannot do a coronally advanced flap or laterally repositioned flap for in case of a palatal area, because a palatal mucosa is extremely thick and it has no elastic fibers. It is a keratinized part of the oral cavity. Okay, so while reflecting the palatal flap, you should be very careful because it is thick, so you give more force, chances of tearing the flap. Okay, so while doing palatal flap surgeries you should be very cautious, right? Okay, now coming to apically positioned flap. The apically positioned flap, okay, apically positioned flap is predominantly done for crown lengthening cases. Okay, so in case of a crown lengthening, okay, crown lengthening means what? I'm increasing the height of the crown. I'm increasing the height of the crown so that I can place gingival margins or finish line so that I can give a cap or a crown or a bridge, whatever it may be. So when I am violating the biological width, say for example 2.04 mm of biological width is not present, then what will happen is that part of the crown is going to hit the bone. It is going to cause continuous pain, irritation, eventually bone loss and tooth loss. So we will be discussing this when I talk about crown lengthening. Okay, so when there is violation of biological width, we need to do a flap surgery to increase the height of the crown. That is what we going to call it as apically positioned flap. This apically repositioned flap, it varies from the original Widman flap in that way. It is going to increase the width of attached gingiva also. Okay, it is going to increase the width of attached gingiva also. Fine. Okay, it is very similar to original Widman flap. So I'm going to give two vertical releasing incisions. Okay, two vertical releasing incisions, and then I'm going to raise the full thickness mucoperiosteal flap, do osseous recontouring, and then so that I can maintain the biological width, and then I'm suturing it back to the apical position, that is at the level of alveolar crest. Okay, what is the apical position? The desired height I want. Say for example, I need 2 mm of crown, I need 2 mm of tissue to be removed to maintain my biological weight. Then I will do 2 mm of osseous reduction and I will place the gingiva over it. Okay, so apically repositioned flap, again it becomes a displaced flap. Okay, 2 vertical dressing incisions, full thickness flap, doing a osseous recontouring, positioning the flap apically. Apically repositioned flap increases the width of attached gingiva also. So apically repositioned flap was given by Neighbors in the year 1954. Okay, so this is about apically repositioned flap. So the next one what we are going to see is, as I told you earlier, management of papilla preservation and conventional flap technique, isn't it? So the conventional flap, what I was talking about is the Kirkland flap, modified flap operation. Conventional flap, just giving circular, interdental, raising the full thickness mucoperiosteal flap, doing a nice curettage, suturing it back to the original position. Right now, the next one what you are going to see is the papilla preservation. Papilla preservation flap. As I told you earlier, why you need to do papilla preservation? Because to maintain the adequate blood supply, especially in anteriors, to maintain the aesthetics. Okay, so I'll tell you 3 techniques to do maintain or to preserve the papilla. So the first technique what we are going to talk about is this one. This is a conventional papilla preservation flap. Papilla preservation flap. In conventional papilla preservation flap, what I'm going to do is, most of the times or 100% of the times, papilla preservation is done in cases of midline diastema or spacing in the upper anteriors or lower anteriors. Okay, so what I'm going to do is, I'm going to give a circular incision. Okay, I'm going to give circular incision. Am I extending internally? No. As of now, I'm giving just circular incision. And then this is the buccal aspect. Okay. Palatally, what I'm going to do is, as you can see here, I'm giving a semiannular incision. So I am not breaking the papilla. I am not breaking the papilla here, as we do in conventional flap surgeries like Kirkland or a modified flap operation. Instead, what I am doing is, in the parietal region, I am giving a semilunar incision. So I am reflecting this entire portion, as you can see here, the entire portion buccally. So I am not breaking the internal papilla. I am just preserving that papilla and I am raising it buccally. And again I am suturing it back. Okay, this is a bit technique sensitive. Papilla preservation flap is a technique sensitive procedure. Okay, so you should be very cautious in doing this procedure. So okay, now coming to another few modifications. First one is the modified papilla preservation technique. So in modified papilla preservation technique, what I'm going to do is, I'm going to select a case where I'm going to do a modified papilla preservation. Say for example, if the interdental spacing is more than 2 mm. Okay, if the interdental space is more than 2 mm, then I'm going to choose the technique called modified papilla preservation. What I'm going to do is, I'm going to give an horizontal incision at the base of the papilla. Okay, a sulcular followed by horizontal incision at the base of the papilla followed by sulcular. What I'm going to do, I'm going to reflect the entire papilla palatally. In conventional, I'm giving semilunar incisions palatally, so that I'm going to raise the flap buccally. Okay, whereas here what I'm doing, I am giving incisions at the base of the internal papilla. Okay, base of the internal papilla, and I'm reflecting the flap palatally. This is modified papilla preservation. Next one what we are going to see is the simplified papilla preservation technique. So in simplified papilla preservation technique, what I'm going to do is I'm going to do the procedure in patients who are having internal space of less than 2 mm. So if the patient is having internal space of less than 2 mm, okay, I'm going to do a simplified papilla preservation technique. So what I'm going to do is I'm going to give an oblique incision at the base of the papilla, and I'm going to raise the flap palatally again, similar to modified papilla preservation. Okay, so in modified papilla preservation, I'm going to give an horizontal incision at the base of the papilla. In simplified papilla preservation, I'm going to give an oblique incision from the base of the papilla. Okay, so in this way I'm going to preserve the internal papilla for the adequate blood supply and also to maintain the aesthetics. So I'm going to raise the flap buccally. Okay, so these are all the few techniques of papilla preservation. So we have talked about three techniques. One is the conventional papilla preservation technique, next one is the modified papilla preservation technique, then is the simplified papilla preservation techniques. Okay, they're predominantly done in patients who are having interdental spacings or midline diastema. Fine. Now coming to the last one, that is the distal wedge procedures. So distal wedge procedure is very simple. It is going to eliminate, or it is going to remove the pocket distally to last molar. The one thing which you should keep in mind is vital structures and the position of the ramus of the mandible. Okay, in case of lower. So if it is very close, you cannot do a distal wedge procedure. Very simple. What I'm going to do, I'm going to give two horizontal incisions which is connected by another incision perpendicular to it, and I'm going to remove this tag of tissue. I'm going to do a nice curettage in that area, and I'm going to close that area. This is called as distal wedge procedure. Okay, so we have talked about various flap surgeries, and we have talked about the classification of flap design, flap reflection, flap elevation, various flap techniques as well, and incisions. A lot of incisions we have learned today. So just have a quick recap. Watch this video again if you are having a little bit confusion in any of the aspects. I'm damn sure you can solve any MCQ pertaining to periodontal flap surgery. Okay, so thank you so much for watching this video. Have a great day. Thank you.